Welcome to this Scientific Digest session following an excellent hot topic on difficult to treat rheumatoid arthritis. I'm joined here by Professor Jacob van Laar. Thank you for speaking to us. So I'll just start off by asking a question about what we mean by difficult to treat rheumatoid arthritis. It's a fairly new concept, so could you tell us a bit about it?
Yeah, it's a fairly new concept, although of course we know that some patients are difficult to treat, and we've been knowing that for a number of years. And of course a lot of emphasis in rheumatology research has been placed on early RA, which of course has led to much improved outcomes. But in clinical care, we notice that there are still patients who are difficult to treat for different reasons. And for example, I see a lot of patients, tertiary referrals with this sub problem. I've noticed that a lot of these patients are cycling through DMARDs, biological DMARDs, conventional DMARDs, and some of these patients tend to have a different condition, or they have other problems that contribute to difficult management. So we have sat down with a group of European investigators to come up with a definition, and based on the definition also with points to consider in terms of management, and that's what I presented in the hot session.
That's great. Could you tell us a little bit more about how this concept first arose and the work that went into coming up with the EULAR recommendations surrounding difficult to treat RA?
Yeah, so it was a kind of a natural growth process. So we started to have conversations with colleagues across Europe, and our impression on this is something, an area of unmet need that we need to explore in greater detail, and that resonated with colleagues, and so we sat down together and I thought maybe we should do this under the umbrella of EULAR. So we drafted a proposal for a task force, which was approved by EULAR. And then, of course, we went through the EULAR process, with meetings, consensus meetings, surveys, and that ultimately led to the points to consider paper that we published this year.
Just to give it a bit more of a clinical context, so what would it mean for patients when they come into a clinic, perhaps by maybe a healthcare professional that might be seeing them for the first time with a diagnosis of difficult to treat RA? What does it mean for that health professionals when they come across these patients?
Yeah, I think in many cases these patients are not labeled already, when they refer to us. So they would be labeled with, could you please see this patient? We've tried this and that. And then, of course, we go through the disease history, and we have, of course, a dialogue with the patients, do a physical examination, and then we may come up with the conclusion, this fulfills the definition of difficult to treat rheumatoid arthritis. And that's kind of like it's almost like a pause button on your screen, and because it would mean that you would not automatically think, what's the next DMARD that we can try, which is the usual referral reason, but we would kind of press on the pause button, and this could set in motion, more comprehensive investigation of the patient, including ultrasound, for example, including evaluation of the psychosocial aspects that may contribute, obesity, fibromyalgia. So in a way, it's I think the whole purpose of the whole of this management exercise is, please start thinking about what's contributing to the patient's difficult to treat disease.
Yeah. And that's really good, and I'm glad you stressed the importance about the cycling of therapy that we see in a lot of patients that are not responding to therapy. And perhaps just a final question from a patient's perspective, what would it mean for them to have this have this label perhaps of
Yeah.
difficult to treat RA, how might it impact their disease course?
Yeah, so in a way, this is an example of personalized medicine, right? Not personalized in the sense that we have a biomarker and tailor our DMARD therapy accordingly, but rather, what are the patient or social factors or biological factors that contribute to this condition. And so if a patient is obese, you would focus more on the patient losing weight. And we know from studies that this can be a very successful approach in improving response to DMARD therapy, for example. Smoking cessation, of course, is a hugely important thing in a clinic. Of course, we can't resolve poverty. That's a kind of a social problem. But we can, of course, help patients cope with their disease better. We can help them adhere to treatment better. This is another issue with some of these patients. And in some cases, there's also a subgroup of patients who probably have a biological type of refractory disease. And Buch has presented about this in this session. And this may be linked to a type of synovitis which is called pauci-immune synovitis. And so maybe we need different drugs in the future for these patients. So I think, it's like providing clinicians and patients with tools to maybe change gear and maybe focus on other things. So for a patient, this could mean a little bit more hope. Although, that said, I think, getting patients to quit smoking is a challenge, as you know. So there are things that we would require from patients that may be not so easy to implement.
That's great. Thank you so much for this summary. And I'm glad you mentioned about refractory disease. And I'll be speaking to Professor Buch about what refractory RA means and how it might sit into difficult to treat RA shortly. But thank you for joining us. So we are now joined by Professor Buch, who has been chairing the Difficult to Treat Hot Topics session. It's a pleasure to have you, Professor Buch.
Thank you.
We've just been speaking with Professor van Laar about difficult to treat RA. Could you please tell us a bit about refractory rheumatoid arthritis and where it sits within difficult to treat RA?
Yeah, sure. Well, thanks for having me, first of all. So, yeah, refractory RA, I mean, interestingly, the term is very long-standing in the history of medicine, not just rheumatology and rheumatoid arthritis. So whether we call it refractory or resistant RA, see it as a construct within the wider sort of terminology of difficult to treat RA. So as Professor van Laar will have explained and discussed with you, difficult to treat really encompasses quite a broad population of patients with challenging features of rheumatoid. Refractory disease, I think the terminology that we all associate by virtue of its name implies resistance to drug treatment. So it's particularly focusing on patients that have repeated resistance or inefficacy to pharmacotherapy. That's included in the difficult to treat definition, but you could suggest that those difficult to treat features that we recognize in our patients don't necessarily have to be part and parcel of actually resistant disease. So I suppose refractory RA within the current conversation to difficult to treat would be seen as a particular patient group to focus on that isn't being driven solely by symptoms or factors that are not related to ongoing active inflammatory disease, I suppose. Having said that, if the definition for difficult to treat includes patients that have cycled multiple treatments, but those other two criteria within that allows patients to have, in essence, drivers that have led to that cycling. And so within refractory RA, I think we'll probably recognize in our clinical practices patients have cycled may not have very clearly evident inflammatory disease. And I think it's important we not separate out, but we distinguish them. So by refractory, it's meaning particularly treatment refractory, repeated treatment, different mechanism of action. And in there is implicitly talking about something that suggests a refractory biology of disease, I suppose.
So that's really good. Professor Van Laar highlighted that perhaps is a small subset of patients that truly don't respond to the medications they've cycled through. So what do you think might be needed for this small group of patients going forwards? Because we've only got a limited set of options.
Yeah, I mean, a small group of patients, but impact significant. I think first it's really important to highlight that. These patients are the ones that would be at biggest risk of the major consequences of rheumatoid. In terms of what is there for them, that's the challenge, that we do have an array, obviously, of treatment options with biologic and targeted synthetic. So being refractory doesn't have to necessarily mean failed all. But I think certainly it's appropriate to consider other trials of therapies that may not have been tried. But I think you're right. There is a space, there is a group of patients that's emerging that have failed all these multiple therapies, are clearly refractory, clearly have active disease, and there is no obvious treatment solution. So that then speaks to understanding the basis for their disease, identifying new targets, new therapeutics. So that whole pipeline of therapeutics needs to continue, not just for this population, but particularly to address, I think,
I'll next ask you a question that actually I asked Professor Van Laar as well. It's about what health professionals could do when they see someone with a diagnosis of perhaps refractory RA. Anything that you would suggest to focus on?
I mean, notwithstanding, as you said, ensuring that, trialing therapy to try and change the complexion of their disease so it's controlled, I suppose it remains important to look at the wider comorbidity of these patients because they'll be particularly at risk. So first and foremost, yes, it's getting disease under control. It's addressing those comorbidities. It's working with our health professionals, our nurse specialists for counselling and education, to highlight to the patients the importance that actually need to look after these other components of their health, not just related to their joint disease. Explain the challenges. It can be very difficult for the patient. We may come on to that later, but it can be very difficult for the patient to understand why they're still in this refractory state. But from a health professional perspective, I think it's ensuring that we do as much as possible to minimize the discomfort, the distress, obviously identify therapeutic strategies or alternatives or option, but also address the other factors, address pain, address other symptoms that will be heightened as well, and comorbidities, so lifestyle risk factors, all that kind of thing.
Yeah, I think that's great, and actually that answers my last question, which would have been about what it would mean for patients to have refractory RA. And I think you summarized it really well with regards to focusing on the comorbidities and stressing the importance of controlling it. So thank you for joining us. It's a pleasure to have you. So that concludes the Scientific Digest on difficult to treat rheumatoid arthritis and refractory RA.